So, first of all, thank you to you for being with us today.
My
So,
pleasure.
good evening, all the students present here. Our speaker for today is Dr. Arun Raja. He is a senior clinical fellow, critical care guys at Saint Hospital in UK. He's currently working in UK. Also, he'll be taking your session today on obstetric emergency CCS session. Thank you, sir. Once more, you can start your class.
Hello, everyone. Yeah, thanks, Fatma, for introducing me. As she said, I'm currently working in London, and I passed my EDIC exam after taking a course with FOSS Academy last year in 2024, which was really helpful in making me successful. So I want to contribute back to the academy by helping out others as well. So I'll be taking few classes, few sessions on obstetric emergencies. This is going to be my first session. So first of all, congratulations everyone who is participating today for clearing part one and applying for part two as well. So you are taking a big step towards your career. EDIC exam is going to help you out in multiple ways in your career and getting advancing in your career. And you have done a wise decision by joining the FAST Academy because this is one of the very few courses available for EDIC Part 2 in particular. The EDIC preparation course given out by the ESICM, it's way expensive and you don't get as much chance for like mock like scenarios for the exam. And it's a different exam compared to other critical care exams. And it's divided. The part two is basically consist of two sessions, day one and day two. Day one is the computer-based assessments, and day two is clinical case scenarios. And we will see in more detail about them. So objectives for the class today, just to orient you towards EDIC Part 2 exam. I don't know how many are aware of how the exam is going to be. So as I said, it's going to be 2-day exam. Part 1, it's like a 30 minutes exam. You get 3 sessions of 10 questions each in the computer-based sessions. It's going to be like a rapid-fire quiz-like exam. You need to be very quick in reading the questions and answering. And day 2 is going to be like few sessions of clinical case scenarios, which we will see today. So it will be a series. It will start with a clinical scenario, clinical Vinay, and followed by a few questions. Then the case will progress. The patient will develop more complications. Then subsequent more questions, another scenario, another question, like that. This session is going to be more of a practice session for you guys. You all know the theory. You just adjusting to the exam kind of scenario and sharpening your answering skills. That's what is going to be making like helpful for you and make you successful in the exam. So we will revisit some of the pertinent obstetric topics today, and I'll try and modify your answers according to the expectations of European or UK standards. Some ground rules. Let's keep this as much interactive as possible and use this opportunity to come out and talk, like reply, answer in English, and get used to that, get accustomed to answering questions in the exam. That's going to be really helpful for you. And may I request to keep your videos on so that I don't feel I'm just talking to the screen. It's helpful to interact as well. So whoever can, please keep your videos on. And I already see your names on the screen so that I can ask questions. So we will do like this round robin kind of questioning. I will start with, I have a list of your names. So maybe I can start with Salah, Then we can progress one by one so that each of you get a chance to engage and answer. And practice answering in a structured way so that you can get maximum marks. And I will give you the answers so in the way which is expected in the exam, so you get an idea how you need to answer comprehensively. And feel free to interrupt and clear your doubts. Uh, I know I can see your names. It would be really helpful if you can unmute yourself and introduce yourself, like what you're doing, what level of training you are in critical care. Salah, do you want to go first?
Hello, doctor. Sorry, I am in duty. I cannot talk. Just I can listen. Sorry for
That's
that.
absolutely fine. That's good to know. Anyone else? Whoever is available, if you unmute yourself and introduce yourself, then we can discuss. I can ask you the questions first.
So, hi, I'm Haytham. I'm Haytham Al-Amli from Palestine. I'm a critical care specialist now in Palestine. Yeah, I completed
First.
my fellowship like 3 years ago.
Great. Perfect. Thanks, Aitan. Who is the next one? Al Mokhtar, are you available?
Yes, also I'm internal medicine and I'm doing also MICU specialist.
Great. And you are free to answer, right? Fine. And Dr. Mohammad Raha?
I'm driving, so I'll try. Once I can manage, I will definitely I will be participating.
Sure. If there is no reply, we will move on to the next person. I didn't get a reply from Dr. Mohammad Raha. Let's move on to Lee Ratnakumara.
Hello, I'm from Sri Lanka. Currently, I'm
Oh,
working
great.
as an acting consultant in the intensive care unit. I did my training in 2022 in Sri Lanka.
Oh, great. Thanks for having. Nice to have
Hello.
you here.
Hello.
Yep. Yes. Dr. Mohammad, welcome back.
Welcome. Thank you. What?
So you are available to answer, right?
Sorry, I just joined now. What is the
Okay.
question?
No, I'm just getting the introductions done. I'm checking if everyone is available to do the questions.
Yes, available. Okay.
Yeah, thank you so much. Ravi? Okay, item is here. Christina?
Hello, I'm Christina. I'm from Spain and I'm a consultant in intensive care, but now I'm working in Ireland.
Great. Nice to have you here. Okay, and Dr. Rajat? He's not there. Fatih?
Yes, hello. I'm originally from Egypt. And currently I'm working in UK as an ICU specialist as well.
Okay, great having you here, Fatih. Priyanka?
Hello, I'm working in Safdarjung Hospital in Delhi.
Oh, nice. Great. And Gibran, do we have you here? Dr. Gibran Khan? Fine. So let's not waste more time. So we have more senior people here. It's just about getting the practice of Gibran has messaged me. That's fine, Gibran. We have enough people to answer it, but if you want, you can type in your answers in the comment. I will have a look. So these are the ground rules for this session. We will try to finish it within like 45-50 minutes. So the case starts like this. You're called to an emergency code blue in the delivery suite as part of the cardiac arrest team. So the patient is a 37-year-old primey with severe preeclampsia, 39 weeks gestation, which was admitted like 3 hours ago in spontaneous early labor. She collapsed following an intense uterine contraction with no respiratory effort. Upon arrival, like 90 seconds after her collapse, CPR is still ongoing. As the most senior doctor in Athens, the resuscitation team is looking to you to lead the resuscitation effort. So the questions in the EDIC.
Sir.
Yeah.
Sir, can you
Yes,
increase
Ravi.
the size of image?
Sorry, Ravi, I didn't get you.
Can you increase the size of image of questions?
Size of the question.
Yeah, it's very small.
Okay, let me see. I need to come out and share it again. Thanks for letting me know. Right. So the questions in EDIC exam is going to be really lengthy. You need to have a lot of energy to go through that and make notes of the essential points. Before the session, like each case for the CCS, it will happen over like 2 hours. You will have 4 cases, 2 long cases and 2 short cases. Before each case, you will have some time to go through the initial scenario and make notes and prepare yourself in the mind. Then the scenarios change and you will get more questions. So feel free to have a paper and pen and note down the important points. So I've started with a small clinical case scenario, but in the actual exam, it may be much bigger than this. So who wants to go first? Salah, do you want to take this and try and answer this? Or whoever is free? I think Salah is busy in the duty. Dr. Al-Mokhtar?
Yes. Can you go back to the case, please?
Yeah.
Okay. So now, once you have resuscitation, we have to continue CPR to regain ROSC. And then we start with ABC.
Yeah.
ABC, we make sure the airways are protected, call anesthetist for incubation, and we starting CPR. A gynecologist must be there for early intervention, and we continue resuscitation.
Right. Anything else? So the examiners
we do
won't...
ABC investigating for the child to ultrasound to make sure it's viable and see blood test and ECG. But I think the prioritizing to ABC to achieve ROSC for the patient.
Right. So in the actual exam, the examiners is going to keep a poker face. They won't give any positive feedback or negative feedback. If they want you to answer more, if they are not satisfied with your answer, they will just say anything else. They will give prompts like once or twice with every question before moving on to the next question. So if they are suggesting like anything else, it means your answer is inadequate and you need to come up with more broad answers, or you need to expand on your answers. Dr. Mohammad Raha, do you want to add on anything to what Al-Mokhtar said? Or anyone else? It's open to the audience now.
I will also inquire about use of magnesium sulfate in this patient, because this is a severe preeclampsia and the patient has suddenly collapsed with no respiratory effort. So this could be a feature of magnesium sulfate toxicity. Or I would also like to rule out any antepartum hemorrhage and placenta previa might be there. So concealed also, I will like to go for an obstetric opinion. And I will also get an ultrasound abdomen done to rule out any concealed hemorrhage, antepartum hemorrhage.
Excellent suggestions. Anyone else want to add anything? Anything else? This is going to be the examiner asking you. Anything else?
We start with positioning the patient and consult this OP doctors for possible and CS, emergency CS.
Excellent suggestions.
After confirmation viability of the fetus.
Right. So when do you want to do the perimartum cesarean section? At what time do you decide you want to go for C-section?
Within 6 minutes, what I remember, within 6 minutes of collapse.
Yeah.
Starting with.
Any other answers? Do you want to add anything else?
The European guidelines 4 minutes, the American 5 minutes, so it's 4 to 5 minutes.
Yes. So you start the decision at 4 minutes, and ideally within 5 minutes you should deliver the baby, which is not always possible, but this is what the guideline says. Yes. Anyone else?
Sorry, here, can I ask you something?
Yeah.
I have to mention need to be intubated and ventilated. We started in strobe, we do compression, we ultrasound to see if fetus is viable.
That's definitely there. I'm just looking for few
Just in the
moments.
cross match. So I have to mention all this in it because we think maybe it's
Yes.
concealed bleed. We have this in the cross match prepare O negative if we need it as urgent. We call a theater room for possible delivery because we the time within 5 minutes.
Yeah, so in that note, we don't shift the patient in arrest. While the arrest is still ongoing, we do the perimortem C-section at the same place unless there is ROSC and the patient is stable enough to be transferred. Yeah.
Yeah, definitely.
And yeah, you do need to like come up with different answers as long as the like examiners is ready to move on to the next question. You need to keep coming up with different, try and answer as much as possible. Don't repeat the answers, but try to answer like go to a different section of answer. If you answer in a structured way, you can get more marks. I will give you the answers now. Yeah.
Neonatology also should be informed and should be ready for.
Yeah, exactly. So see, with time you are
multidisciplinary
getting
team.
more ideas. With time you are getting more ideas. So let me see what I have in my answers. So first thing, I'm going to get a brief handover. In UK, or the advised handover method is S-bar handover. You go there, you get a quick handover. What's the situation? What's the background story? And S stands for situation, B stands for the background, A stands for the action, and R recommendations from the team. So this hardly takes like 30 to 40 seconds. Then we should ensure in UK and European standards, like they have a different codes like arrest calls. In a general cardiac arrest, the obstetrics and neonatal team won't be there. So we need to specifically ask for obstetric cardiac arrest, including a neonatal team, if you want them to be present in the team. So this patient, definitely we need the neonatal team to be there in case we are worried about like perimortem C-section. So that's one thing to confirm when we arrive there. So as you said, we will continue with the chest compression, and positioning, as Dr. Mohammed mentioned, is very crucial. That's going to carry a bit more mark in this particular scenario. Ensure there is a proper left lateral tilt, or if it's not possible, manual uterine displacement. We should be quite conversant with how are we doing to do that and why we do that to prevent aortic cable compression in any pregnant lady more than 20 weeks. And minimal interruptions, see if there is a shockable rhythm as soon as defibrillator is available. And you did mention intubation, but we don't try and intubate all the patients who are in arrest. Why in particular in pregnant women, we are worried about early intubation?
Edema can develop and difficult airway management will be there.
Yeah, of course, any pregnant woman, we are anticipating difficulty in intubation, but there is also the risk of aspiration with any pregnant lady. So that's why we may get away with IGEL insertion or LMA insertion in other cases, and we try and intubate after we achieve ROS in many situations. But in a pregnant lady, this is one occasion where we try and intubate as early as possible. And as we already discussed, perimortem C-section, we discussed the time and the place. We try not to shift the patient to a theater while the arrest is ongoing. We try and deliver the patient on the spot of arrest. So that's very important. And the person, do we need an obstetrician to do it, or who can perform the perimortem C-section?
Supposed to mean anyone, even the emergency physicians can do it.
Exactly. So it doesn't need to be a specialist. Any MBBS doctor can perform if they are confident, they can do it. And what kind of incision are available, like in an emergency?
Paramedian incision, longitudinal paramedian incision.
So what's given in the guidelines is suprapubic transverse or midline longitudinal below the umbilicus. So that's what it's suggested in the guidelines.
I heard that maybe my information are outdated, but it's classically it was in the past to make, because we want to make it as fast as possible, to make it longitudinal incision, supraumbilical longitudinal incision, but maybe they changed the guidelines to horizontal. I'm not sure, but I think horizontal it will take time to deliver the baby. You will never be able, because it needs a lot of dilatation. But longitudinal upper incision, it's much faster.
Yeah, whichever the operator feels comfortable. But these terms are the what is used in guidelines. It's better to stick with the same terminologies so that we can avoid confusion and we can get our marks and move on to the next question. So we discussed evaluation of reversible
can I ask you
causes.
something here?
Yes,
Do we need to do POCUS first to make sure that the child viable? Then we go for C-section. Because maybe you have concealed bleed. Or just
no, it's not advised. So the reasons why we do a perimortem C-section is not just to save the fetus. It's more for the mother, isn't it? Like if we deliver the fetus, the perfusion for the mother is going to get better, and maybe that's the reason why the mother arrested in the first place, like having the fetus inside. So it's not only to save the fetus, but predominantly to save the mother. So we don't wait to check if the fetus is viable or it doesn't alter the decision making. So we don't waste time doing POCUS. Yes, I understand we need to rule out reversible causes, but if there is no like expertise available in doing POCUS, you are the one leading the team, and within 4 or 5 minutes we need to decide on delivery. The C-section takes like preference over doing the POCUS. Of course, we try and do like rule out reversible causes within the time frame possible, but priority is to get the child delivered. And one thing none of you mentioned is eCPR. So this although like it's not available in all the hospitals, this is one point which may have a mark, and you may miss out on it if you're not mentioning it. So in any arrest scenarios, for the purpose of this exam, always mention like ECMO CPR in the like back end. So it may carry a mark, we don't know. So this is how I would structure my answer, and most likely this is how they would have like the answer sheet is available to the examiners. So as long as you say like even close to the answer which I have written here, they will put a tick and give a mark. There will be 2 examiners. One will be giving you the mark and one will be asking you the questions. So they will just tick and give you marks. As long as you list out as much as possible, you maximize your chances of getting the more marks and passing the exam.